Greetings. I'm Dr. Thema Bryant, President-elect of the American Psychological Association. I'm a professor of psychology at Pepperdine University and director of the Culture and Trauma Research Lab. I'm going to be talking with you today about working with conflict and war-exposed clients, considering trauma, culture, and racism. Thank you so much for joining me. I want to start with a positionality statement to tell you some about the ways in which I'm approaching this work. I am a woman of African descent living in the United States. And while I am Black American, African American, I want to name that as an adolescent, I was living in Liberia, West Africa at the time of the Civil War. And as a result of being an American citizen, had the privilege of being evacuated, but also was exposed before evacuation to the realities of war. And so I talk about and approach this work not only based on what I have read and the services that I have provided as a psychologist, but also my lived experience. I am talking to you today from Los Angeles, California, which is a land that has been cultivated historically and in the present by the Tongva peoples and other indigenous peoples. And I'm also presenting to you today from the United States, which, while it is a relatively young nation, developed rapidly, and a part of that rapid development was based on the exploited labor of enslaved Africans. And so I encourage you to take a moment to reflect on the indigenous peoples of the land in which you work and live, as well as recognizing the history of that nation as it relates to labor and exploitation. It is important that we reflect not only in a symbolic sense, but to allow that awareness to then guide and inform the work that we do. I want us to also to attend to the socio-political climate of the war and conflict zone that the persons that you serve are coming from, where they currently reside, and to consider the ways in which the political climate, the socio-political climate has affected your life and has affected those of your clients. It's important that we acknowledge marginalization and oppression in the war zone and conflict zone, and also that we acknowledge marginalization and oppression in our training and in our own practice. So in other words, as we think about the ways in which people have been treated, disturbed, disrespected, disregarded, that is not just something that happens at borders. It is not just something that happens in war zones, but we also want to think about the ways in which marginalization, oppression, racism have shown up in the ways in which we have been trained, what we have been taught to attend to, what we have received less information about and awareness about, and for us to also think about the ways in which that has guided our practice, both in positive ways in terms of being empowered to directly address oppression, and also for us to take a moment to reflect on all of the classes or supervisions or trainings that we have attended that did not address nor acknowledge or prepare us for the realities of oppression in all of its forms and racism specifically. I want us to really have pause for awareness and self-compassion for ourselves as we consider what it means to provide care during a time of war, during a time of conflict, for us to recognize that you all are providing that care in the midst of medical trauma of a pandemic, and that you also individually may have experienced and continue to experience oppression in diverse forms. And so while we are an instrument of care, while we are providers of care, we are also having our own lived experiences. And so I want to name that each of the individual boxes that are present, or wherever you are as you are watching this training, does not tell the full story. And so our awareness is not only for our clients and the world that they have faced, but it is also for ourselves. So we want to consider stress, trauma, and culture dynamics for displaced persons. The first thing I want to bring to your awareness as we think about trauma is that your clients have been or possibly have been exposed to trauma pre-flight, during their flight, during their movement or exit out of that country, as well as after they have left that country or that region. And so when we think about trauma, trauma affects the nervous system. It is not only cognitive, it is embodied. Trauma overwhelms our usual capacity to cope. And so all of us and our clients have everyday stressors, multiple responsibilities and roles that we determine how to juggle, how to carry. And then there are those events that overwhelm our usual capacity to cope, that can overwhelm our emotional resources. And so from that place, our clients may experience a sense of hopelessness, a sense of fear, a sense of powerlessness, even terror. And often we are drawn to focus on the war or the conflict, but it is important during the intake process to also get a sense of the potential pre-trauma even before the war. We also want to consider what the process was like in terms of a person's migration or a family's migration, and the challenges and potentially violence that they experienced during that movement, as well as what their experience has been, where they are settled now. And perhaps for some, there have been multiple stops along the way, and what those experiences have been is important as well. So, what are some of the possible experiences that people have had who are displaced? The first is witnessing violence, and the witnessing of violence can include death, the active moment when a person or group of people are killed, as well as in the aftermath, witnessing dead bodies. It is also important to know that your clients may be direct targets of violence, and also experience the loss of loved ones, the loss of safety, persecution. They may face threats, both past and ongoing. Some of those that you serve may be survivors of torture. And we also want to think in an emotional and physical and financial sense what it is like to have a loss of home. And loss of home not only being a physical space, while that is a part of it, not only the home in which they lived, but a sense of community, a sense of familiarity, a sense of connection, a sense of regular routine, and a predictable expectation about the course of one's days and weeks. And as we take in those multiple realities, we are mindful of complex trauma, long-term trauma, as opposed to single incident, acute trauma. And with complex trauma or ongoing trauma, we are aware that the research demonstrates that those types of experiences can disrupt our sense of self. They can disrupt our capacity for affect regulation, emotional regulation. They also can affect the ways in which we form and maintain relationships. And so, with all of the various memories that people are holding, we want to think about the specifics of the events, but we also want to consider the global, broader impact on those that we serve. So clients who've been displaced face issues relating to loss of housing and instability of housing or housing insecurity, facing financial loss, facing physical health problems as well as injuries. And so within physical health problems, we have both infection and injury, but we also have those somatic complaints. And so we know the body keeps the score and the body remembers. And so those physical health problems, the ways in which stress shows up in the body, can be demonstrated or exhibited in migraines, in nausea, in backache, in body ache, and muscle ache. And so we want to attend holistically to the ways in which stress manifests in our not only psychology, but also our biology. Many of those that we serve may also have a lack of knowledge of resources. Also, there is a general lack of resources, but for the resources that do exist, often there have been barriers in terms of dissemination of knowledge and information about how to access those resources. And then I want to name the reality that many displaced persons have faced hostility in their host country or in their host region. And so that hostility may not only come from members of the public, general members of the public, but that hostility can also show up among helping professionals. So those who are in a position who are supposed to be serving, processing the transition, providing the information, providing the physical and mental health care, that those persons, we as providers, are not immune to the stigma, the bias, the racism, the anxiety that people hold often about groups in general, and then towards refugees or displaced persons, especially when they come in large numbers. And so we want to be mindful of those experiences, recognizing because we sit in our capacity as a helping professional, that it will be important for us to create space and to name that this may have been a part of a client's experience. If we don't name it and ask about it, we can fail to communicate that we are a safe person with whom they can share their experiences not only of war, but also of mistreatment. Sometimes those who are in a host country have a sense that people should just be grateful, that there should just be gratitude that they were taken in, or gratitude for the services that are provided, and not recognizing both the loss and the grief and mourning of their own stability and safety, as well as the potential mistreatment and discrimination that people have experienced. Along those lines, I want to name that the persons you're serving may face what some call socio-cultural trauma. In other literature, it's referred to as societal trauma or referred to as oppression. It's named as racism-based trauma, racist incident trauma, and we also look at it in the literature as intergenerational or transgenerational trauma. And so I want to name that some groups, particularly our American Indian communities, also use the term ancestral trauma or ancestral wounds. So we want to really have time in our processing as we're thinking about the treatment plan to document and look at the effects of the loss of familiarity, of being able to freely speak one's language and know that one will be understood and to be able to understand those around you, the loss of active connection with your culture. For those who were majority group members, what it means to now go to a place where you are minoritized. And even for those who were minoritized in the war zone, what it means to then be displaced and now be a part of an even smaller group of persons, and to be even more often misunderstood. We want to reflect with our clients on the loss of community, and then for many, what it means for them to experience a loss of status. And so, whether one had a business or was working in someone else's business, whether they had a status in their community based on their family, based on their roles and their history there, and even those who were students, to think about what it means to go from being a student to a displaced person with an uncertain future is a lot to untangle. It is a lot to process, and it really disrupts our functioning and the functioning of those that we're serving. We also want to think about, for displaced persons, economic barriers in their new country, as well as educational barriers. And so, legally and by various policies, there are often barriers which create limitations to our clients' ability to access jobs, to be able to access housing, to be able to access resources, and to be able to access education. Additionally, we have the realities of acculturative stress, of trying to not only deal with the grief and loss of home, of culture, of familiarity, but also trying to adjust and learn a new culture, a new space, a new place, a new form of context, a new socio-political context. We want to also recognize that those we serve may have faced a fair amount of time where there were no psychological services being provided to them, where there were minimal services, and also where services have been provided by overwhelmed providers and or culturally insensitive providers, and providers who exhibit bias and interpersonal racism. And when we talk about taking a history of someone's treatment, we often will think about asking them what were the topics that were covered, if they received a diagnosis, if they found it helpful or not helpful, and have not always addressed what was the experience like, what were the ways in which they coped when there was not support provided, or when the support that was provided really created additional stress and really created a sense of erasure and at times even dehumanization. I want to name our research documents that these effects show up not only for adults but also for youth. And I know some of you work in particular with displaced youth, and so to be mindful of all of the different trauma exposure, including the societal trauma or their experiences with oppression, discrimination, stigma, racism. So it's important that we end the denial and minimization of racial trauma. Audre Lorde, who is a Black American poet, wrote the words, "This woman is Black, so her blood is shed in silence." And so we want to take a moment to think about who is in the margins of the margins, whose experiences, whose trauma and stress have been less acknowledged or addressed in our literature, in our training, and in the larger social messaging in the media and in the provision of resources. For whom have resources and services been set aside and protected and created and prioritized? And who are the persons whose care has been less attended to, less provided for, less acknowledged. And we also want to take a moment to reflect on the construct of trauma and the history of trauma. And so, historically, as trauma was framed relating in particular to post traumatic stress disorder, the framework was really us thinking about serving war veterans, right? As we think about war, we're not only considering the realities of the displaced persons, but also those who are in the military. And so we consider what is the experience of those who may be facing moral injury, those who may be facing the fear, anxiety, the intrusive thoughts, those who may be dealing with avoidance and hypervigilance, and various triggers. And so we recognize and acknowledge as a field the realities of the trauma of war, including for combatants. And then the category was really broad, and our understanding of it was broadened to include other forms of interpersonal trauma. And so we think about child abuse, we think about intimate partner violence, we think about community violence. And so understanding that those experiences can be sources of trauma as well. Then we want to recognize the societal trauma of oppression and to consider for yourself who has benefited from psychology's silence on racial trauma, right? That in some spaces and places, when we name racism as a potential source of stress and trauma, some people have denied that, have minimized it, have dismissed it. So some people will say, oh, that sounds political, not recognizing that what we acknowledge and do not acknowledge in the field as a whole, when we think about our diagnostic process, it is political, right? All of what we deem to be important or not important is not coming from some objective or neutral place. And at the same time, when we look at psychological science, we see the impact has been documented of racial stress and trauma. In particular, experiences with hate crimes and other forms and manifestations of racism have been found to be associated with post-traumatic stress symptoms. Often persons are not given the official diagnosis because of the criteria A, or the event if it was not life-threatening. And at the same time, we want to recognize what the realities of complex trauma are as it relates to racism, meaning the cumulative effect. So some people will say that war or sexual assault is a capital T trauma, but that racism and other forms of oppression is a lowercase t trauma because they say, well, it is just emotional abuse. And I want to name for you, as you think about those who have been displaced, and even as they were fighting for their very lives and the lives of their family, being denied access to be able to exit the war zone, right? And so what that means in terms of threat of life and livelihood. And we also want to be aware that racism has manifested in violence. And even if a person was not directly targeted by it, we know the realities of vicarious traumatization, right? And what it means to be a part of a shared collective identity with persons who have been targeted as a result of that identity. And so we want to commit ourselves to actively, in our psychological practice, being anti-racist, or being committed to disrupting, dismantling, addressing racism in the lives of our clients. many times when we think about culture, we are tuned into what perhaps are the gender roles, or what are the barriers around language, or what is a culture's understanding of mental health or therapy. And we may be comfortable looking at each of those themes, but never get to the realities of racism. And so we want to actively engage in addressing it, both within ourselves. What are the messages that we have received and even believed? What has been overlooked, or the ways in which in our research some groups have been pathologized? We want to think about in the ways that we even teach trauma and teach treatment, and the ways in which we provide supervision, that if we have been a part of the erasure of racial trauma, that has been harmful, and that there are costs to that. And so as we consider the work that we do to address trauma, that we want to attend to all forms of trauma, including societal trauma and including racism. So, what are some of the common effects that are observed in those who have been exposed to war and those that have been exposed to conflict zones? And as we think about those common effects related to war, we also want to consider culture, both the ways in which people make meaning of their experiences, the ways in which they express their distress, and the ways in which their distress is interpreted by us and by others. And so many people will experience post-traumatic stress symptoms. And so we want to be mindful in our assessments of the ways in which those symptoms can show up. Now, when we think about, for example, hypervigilance, we want to be aware of the additional cultural and racial dynamics around the ways in which hypervigilance is interpreted, right? So when we have clients who come in who are very guarded, who don't feel safe, often our tendency has been to label them as the problem. So we will use such terms as, this person is resistant to care, or this person is not engaged in treatment, and don't always reflect on, is there the ways in which they're showing up really reflective of what they have experienced, what they have been exposed to, and perhaps the ways in which we are providing the care, right? We also want to consider the ways in which depression can show up. And we think about traditional depression, and people showing up with depressed mood, people being slow moving and low energy, and a sense of hopelessness, difficulty sleeping, changes in appetite, a loss of pleasure. So we think about those kind of traditional symptoms. And we also want to be aware that some people's depression and despair can show up as irritability. And often in our line of work, we like clients who come in with, in some way, some appreciation or gratitude, and we can get very defensive or even disengaged ourselves when people show up with irritability, especially when it seems to be directed at us. And so we want to be mindful, especially when we think about minoritized or marginalized clients, of the ways in which we can judge, right, and make these statements or assumptions of, this person or this group of people has a bad attitude. And so we start labeling the attitude and not seeing the despair that is really guiding it, as well as the fear and anxiety. So we want to be mindful of the realities of anxiety, of panic disorder, of substance use, abuse, and dependence. We want to be aware of the ways in which our client's functioning has been impaired as a result of the displacement and the trauma that they have been exposed to. We look at an overarching theme of psychological distress, and that even when people may not meet formal criteria for major depression or for post-traumatic stress disorder, the ways in which they are experiencing distress and the cultural permission or rules that guide the ways in which that distress is exhibited. So many marginalized communities, as a survival strategy, have been taught directly and indirectly not to show their overwhelm, not to show their distress, especially in the presence of people outside of their family and outside of their community. And so when we are not careful, sometimes we can assume by a person's affective display that they aren't the ones that are in need of services. And so we can be dismissive and say, oh, they're fine, they're resilient, let me save this time for someone who really needs it. And we want to be aware that the facial expression, does not always tell the fullness of the story. And so it is important to be able to provide psychoeducation around affect, and also to be tuned into the ways it can be experienced, even if it is not being expressed. We're also mindful that displaced persons can face increased risk of suicidality, and especially as we think about all that has been lost, right? Time, space, place, people, status. It can be daunting to think about starting over, and the grief can be overwhelming, both recognized and unrecognized grief, right? Grief as a result of the loss of loved ones, but also grief around our psychological and cultural, as well as financial losses. We also want to be tuned into and to be sure to assess for sleep and look at the challenges around insomnia. And to know a piece that has been documented in our research, the realities of chronic pain. And so some of that chronic pain is from the stress I mentioned showing up in the body, but some of that chronic pain may also be due to injuries as a result of torture and violence and other forms of violence. We want to consider the experiences of shame. And, we think about shame as opposed to guilt, right? So guilt is about things that have been done, that a person has done. And shame is really about the core of who we are. And so what are the ways in which we may recognize, or we may see in our clients shame and the ways it shows up. So sometimes it shows up in the ways that a client speaks about themselves. Sometimes that shame shows up in self-sabotaging behaviors and self-destructive and self-harming behaviors as well. And we also want to attend to the realities of complex grief. When you think about, again, the layers of loss, and at the same time, when we think about the critiques of our field, being careful not to pathologize what can really be normative when we take in the vast losses that people have faced and continue to face. But we also want to consider, even when it is to be expected, given the numbers of losses, the severity of loss, the ways in which it can really impair functioning for the client, and also their subjective experiences of that grief. So we recognize that trauma, as I named, affects the nervous system. And so in the aftermath of the exposure, We may see in our clients, they may report, or we might even see it in session, responses to being triggered. Some people, instead of the term trigger, talk about awakenings because of the association of trigger with guns. But the term that is more commonly used, most commonly used, is triggers. And so we just think about those experiences that are reminders for clients or that put them back in that state of panic, of fear, of danger. And so, what are some of the ways that our clients may commonly respond when they are triggered or awakened or reminded on a physiological level of the experience of the trauma? And so some respond with fight mode, and so can feel unsafe with us or unsafe in their new community, and may find themselves getting into a lot of altercations with others. Some respond with flight mode, and so never feeling safe anywhere and continuing to move from place to place or relationship to relationship or from therapist to therapist. We may also see or hear reports of them freezing. And so disconnecting, dissociating, feeling shocked or stunned or immobilized. And after having that experience, sometimes there can be the shame and self-blame about not being able to rally or mobilize themselves in the ways they would have desired. What you may be less familiar with is the response of tend and befriend. And that is really about looking for connection, looking for safety. And at times, this can even show up with trying to build that connection with persons who seem to have the power in a particular place or dynamic that they are hoping will keep them safe. And so, what are the ways in which, when someone is traumatized, that it affects their relational life? So, we want to actively reject approaches that pathologize refugees and other displaced persons. We want to take a balanced view of refugees that acknowledges their symptoms of distress, and to also acknowledge the what many may exhibit in terms of psychological resilience, hardiness, and strength. And so, in our intake process, to take note of the strengths of our clients, and not only to take note of them for our own planning and documentation, but also to communicate those to our clients. I do want to name a critique you may or may not have heard as it relates to this term resilience. That some have talked about this focus on resilience has left the process, the recovery or healing process on an individual level, right? That it's just up to us to foster resilience in individuals and not addressing the systemic, structural, societal issues that people are facing, right? So, along with working with your individual clients, for us to think about the ways we can utilize our psychological science to transform systems and environments so that resilience to that level is not perpetually being required. We do want to also recognize the incredible pro-social behaviors demonstrated by displaced persons, the ways in which people share, the ways in which they come together, the ways in which they create new community, the ways in which they attend to the needs of others, not only themselves. And we see that across war and conflict zones. And it is important to assess and ask people those questions of, who are the people, not only professionals, but who are the everyday people perhaps that helped them, on their journey and with their migration, that have helped them to get settled or to try to get settled, and perhaps who even made sacrifice and attempts to help them while they were still in the conflict zone. We also see among many clients a sense of optimism. So while the despair is there, some people are able to hold on to a sense of hope, a sense of planning for the future, a sense of what they are looking forward to when they can get back home or when they can reconnect with their families. And so we want to be sure that as we are conceptualizing our clients, that we are not only seeing the needs, the pain, the trauma, but that we're also seeing the strengths, the gifts, the possibilities, and to communicate that we see those things to our clients and to both individuals and families. So there are some limitations to standard protocols of treatment. When we think about trauma-informed care and trauma recovery interventions, they were primarily developed and intended for clients who are currently in a safe and secure environment. But refugees have appropriate anxiety and fears based on continued threats to their safety, right? So we want to really take that in, even when we consider the term post-traumatic stress, right? That assumes, even necessitates that the trauma is over, right? So when we think about the term being developed with soldiers and veterans, the idea is, they would go off to war and then they would come back post-trauma, and then psychologists would help them to recover. So we want to consider what it means when people still don't really have a sense of safety or security in their present lives as we are providing the care. Some people have used the term continuous traumatic stress, right, or ongoing traumatic stress. So we want to really be mindful of that as we are doing this work. Many interventions, traditional models of trauma recovery don't address the major sources of distress, such as resettlement after leaving one's country unexpectedly and indefinitely, right? That we don't even have a timeline, right? And by the suffering of marked losses. And so many of our models for trauma recovery focus on single incidents or single events, right? There was a perpetrator, right? And then this happened on this particular day. Or even if we think about longer term trauma, such as child abuse, you have the long-term aspects present, but not attending to loss of home, loss of country, loss of language, loss of social support, loss of a shared cultural, spiritual, political, and religious views, right? And so we want to consider the need for cultural modifications and also culturally emergent interventions, right? So cultural modifications is when we take these standard protocols and we infuse and intentionally make shifts and changes to the protocol to be culturally sensitive. But we also want to be aware that there are culturally emergent interventions or interventions that were created for a particular group of people and primarily by persons from that same community, culture, race, right? And so then those are the realities of culture are not an afterthought. It's not, let me just adjust this to make it more relevant to someone of a particular cultural background, but it was actually, these were actually designed with this population in mind. We also need to expand beyond trauma symptoms to solution-focused coping to address experiences and challenges of resettlement, including fostering capacity And I already mentioned this caution around resilience, right? Of not just looking at individual psychology, but enhancing people's ability, capacity, skills to engage the systems that they are interacting with or being shaped by to be able to even advocate for themselves, right? So much of our standard protocols are around coping and not so much looking at active engagement and navigating systems. And some people, based on your training, may think, well, that's not the role of psychology. We just help people to cope. And to that, I would say there is not just emotion focused coping, but also problem solving coping. And so we want to be intentional and mindful of that. So there are studies that are done on the treatment efficacy with asylum seekers and refugees. And we have systematic reviews and meta-analysis of randomized controlled trials assessing the efficacy and acceptability of psychosocial interventions compared with control conditions. These treatments are based primarily on cognitive behavioral interventions with a trauma-focused component. And so they include psychoeducation, experiential reflection on affect and cognitions, breath and body work. So, for example, trauma-informed yoga or using other forms of movement, as well as relaxation training. And most of these interventions provide some homework so that our clients can continue practicing these skills and applying these skills. And when they return in the following session, we can help to problem solve about what were some of the challenges with applying the strategies. So in this study, there were 26 studies with 1,959 participants. And the meta-analysis of these randomized controlled trials revealed that psychosocial interventions have a clinically significant beneficial effect on post-traumatic stress disorder, depression, and anxiety outcomes, that there were decreases in each of those. And this beneficial effect was maintained at a month or longer follow-up, depending on each study. There's also research that shows that narrative exposure therapy is also promising with refugees. And so we want to think about creating spaces within our intervention for psychoeducation, right? Education around affect, education about trauma responses, education around coping, including problem solving. We also want to create space for relaxation training and to create space for that narrative approach and exposure therapy for once we have provided a foundation of some skills for emotional stabilizing and grounding for people to be able to speak about their experiences and their exposure. So there are also interventions that have been developed for places, especially where there are not a lot of mental health professionals. So there are some interventions that can be provided by both professionals and non-professionals. So one example is common elements treatment approach, which is also a cognitive behavioral approach with positive improvements in anxiety, depression, substance abuse, social functioning, and post-traumatic stress symptoms. This work has been done in Ukraine, Thailand, Ethiopia, Zambia, Thailand, and Colombia. And the standard protocol is 8 to 12 sessions. There's also a shortened version that has 5 sessions. And the components include psychoeducation, skills building, a safe space to share difficult memories, problem solving, and behavioral activation. So some of the limitations that have been reported with this model, this intervention, is some people, some clients complaining for randomly being assigned to the brief common elements treatment approach and desiring longer services, more long-term services. So while the brief intervention also has benefits to it, as we can imagine when we think about all that people are facing. 5 sessions is very minimal, and often people are needing and wanting more support. There were also complaints in this research study of the sense that the researchers were being culturally inconsiderate in making multiple attempts for follow-up for not only months after, not only 1 month after, but continuous attempts for longitudinal evaluation. And so, we think about what it means for us, of course, as we say, like the strength and knowledge that we gain from longitudinal studies, but we can also think about for those who are needing and wanting care in the moment, even with informed consent, not really feeling that it is appropriate once I have ended this therapeutic relationship for this person to, in a lot of ways, continue tracking me or monitoring me or contacting me. So we just want to be tuned into that as we think about our sometimes research needs or evaluation needs, even as we consider that in the long term, the hope is to make a better intervention to serve communities, and also being mindful of how it is being experienced by those who are participants or clients. So as I named, there are cultural modification interventions. The process of making therapeutic goals, language, content, and process consistent with those of the target population to enhance treatment relevance, credibility, and efficacy. It focuses on the treatment challenges presented by refugee experiences and attends to healing and culture. So cultural modifications attend to race, culture, ethnicity, collective memory, including beliefs around one's culture, social history, others' perception of one's culture, and belief systems. It integrates culturally relevant imagery, proverbs, metaphor, and stories in treatment so the clients can make sense of what is being offered. And so I invite you to think about, for the cultural communities that you are presently serving, if you know of any proverbs from those communities. If you have done the research to know what are some of the common metaphors that are used, to even look at some of the stories that emerge from that culture and the ways in which we can use those stories, those proverbs and metaphors within our psychoeducation, within our skills building, when we're doing the relaxation training to think about integrating that imagery. And so we can do that research ourselves outside of treatment, as well as inviting our clients to share those that they may know to really make the process collaborative. So culturally informed interventions, and these are interventions when we think about not just modification and adding culture in the aftermath, but one such example is the multi-phase model of psychotherapy, social justice, and human rights. It is a culturally responsive, multifaceted clinical intervention model that addresses the refugee experience from an ecological, holistic, social justice, and human rights perspective. The therapist attends affirmatively to the client's cultural belief systems and culturally specific migration challenges. The therapist demonstrates reflexivity regarding potential political countertransference and the culture of fear, which has often been promoted regarding displaced persons. So this goes to my earlier point of what are your beliefs and your ideas about the community as a whole of displaced persons? Who are those that you find yourself having more compassion or sympathy for? Who are those that you may have more negative associations with, either based on the experience with a few or what has been shared in the media, or what you even before the conflict were told or taught about this particular racial or ethnic group. Early in treatment, address stigma regarding therapy and the client's cultural identity, as well as other barriers. Culturally congruent emotion regulation techniques and narrative sharing of individual and collective story is also a part of these interventions. And so you want to consider and explore with your client what are grounding techniques or calming techniques that come from their community, right, from their culture. What are the ways in which they saw their parents or grandparents find a sense of peace, right? Find a sense of calm. Whether those persons have ever been to psychotherapy or not, there are culturally emergent, culturally based ways of coping and grounding, as well as healing. So we consider also intercultural counseling with refugees and displaced persons. And so we want to consider the impact of culture on our views and on the views of our clients regarding mental health as it relates to the client provider counseling approach and mental health system in which the services are being provided. We often think about our client's worldview, right? We don't often reflect on the fact that we have a worldview based on both our cultural identity and also a professional worldview, which is a worldview, right? A way of what we consider to be important, what we consider to be priorities, what we have determined is dysfunctional. And so we want to be mindful of the multiple worldviews that are in the room. We also want to consider and address the political narratives that are being promoted, which impact the migration experience. And so, what do people in the new country or new location, what are the stories they have been told about refugees, about displaced persons, about persons from a particular nation or cultural or racial group? And so being aware of those common narratives, political narratives that are being disseminated, and how that then has shaped and influenced the ways in which our clients have been treated. We want to shift away from the idea of culture as a problem to really recognizing the need for cultural humility and culture as a resource. And so culture is more than cultural oppression, and there is more to race than racism. And so with cultural humility, that is a stance of openness, of curiosity, of recognizing the persons we are serving are experts on their life experience. And so we want to learn from them, not just dictate based on this notion of hierarchy of we are the expert and know what's best, but to really be actively and humbly collaborative. We also want to consider culture as a resource. So it is not just a barrier to therapy of, oh, they're from this culture, so they don't understand or respect or appreciate psychotherapy. No, for us to really take in this person or this group of people come from a cultural background that is rich, that has a history that predates psychology, right? So psychology as a field is a relatively young field when we think about human history. So there are many ways that people sought healing and coping and wholeness and care that have emerged and sustained themselves even longer than our practice and interventions. And some of our interventions are actually based on these cultural forms of coping and healing, even when those roots have not been acknowledged. So we want to remain open to innovation and to creative approaches to this work. So we want to consider in particular cultural modifications for Black and other ethnically and racially marginalized clients. And we consider that as many of you may be serving not only refugees and displaced persons, but African refugees and displaced persons who face specific forms of anti-Black racism. And so the adaptations to interventions include adjusting ourselves as therapists and our interpersonal style, adjusting the actual content of the topics and themes that we are covering, and the ways in which we are approaching psychoeducation and skills building, and then also adjusting our organizational policies and procedures. And so we find that when these modifications take place, it has a significant effect on symptom reduction compared to non-adaptive active treatments. And so when we make the cultural modifications, it can enhance the interventions that we are providing and enhance the outcomes. Most agencies utilized more than one category. So they reported therapist-related modifications, content-related modifications, and organizational-related modifications. So it was hard to tease out, which ones were most effective. But there is, based on the data, a thought that a trend that the organizational modifications were the most beneficial. And we can think about that in terms of it being systems wide as opposed to just the individual that is being served, and also it addressing some of the barriers to treatment and to make treatment more inviting and inclusive. So with African displaced persons responding to the trauma of racism, we want to think in particular about the trauma of anti-Black racism. So globally, there is a racial hierarchy, and we see that Black people of African descent, often experience the lowest levels of that treatment, the highest levels of discrimination and stigma. And so it is important with our clients of African descent to assess and explore their experiences with anti-Black racism even before the war, even before the conflict erupted, to explore with them the ways in which anti-Black racism was showed up or was exhibited during their migration process, and also if they have had experiences of anti-Black racism even as they are seeking to settle in their new location. And so racism, including anti-Black racism, can be direct. You can be a direct target, you can be a witness, and you can also experience it from the standpoint of vicarious traumatization. Racism is both historical and contemporary, and it's important to keep in mind it being contemporary, as many people will say, oh, well, these terrible things, atrocities happened a long time ago, and not recognizing the ongoing realities of racism, that it continues to be prevalent, and that it continues to show up not only in covert ways, but also in overt and very violent ways. And so we do not benefit from the silence. In particular, our clients and our Black clients do not benefit from our silence on the trauma of racism. So if you have been working with a client for weeks, for months, and have never introduced the topic or assessed or asked the questions, then it is likely not even showing up in your treatment plan. And sometimes we have avoided assessing because we don't know how we will then treat it. I developed a model on treating the trauma of racism along with Dr. Ocampo. And the themes that we look at around the trauma of racism is first helping clients to be able to acknowledge those experiences. Once we have provided those self-soothing or coping and grounding strategies, having time within session for people to be able to share those narratives and to meet the sharing of those narratives with belief and with support. So we don't want to make dismissive comments like, are you sure? Or maybe you were being sensitive, or, well, I know everybody's having a hard time and, yours is no different. Any of the blaming, shaming, minimizing responses that we would not give to someone around war or around sexual assault or around partner abuse, we want to be careful that we're also not responding in those victim blaming ways for people who experience oppression. We also want to explore with clients the healing of trust and determining who is trustworthy, right? And as I shared earlier, it makes sense that people would have questions about, is anybody going to be trustworthy? And so helping to tease apart the signs or indicators of people who have both been deceptive or manipulative, as well as those who have been consistent or have been caring. It's also important to create space for the healing of trust of oneself. Often, the realities of racism can leave you disoriented, and even though you know it exists, still being stunned or shocked. Important to have space for clients to be able to mourn the losses. What are the things that racism has taken from you? It's also important for us to be comfortable and invite people to be able to express their anger. I like to say it is healthy to be outraged about outrageous things, and racism is outrageous. And so it's not for us to mute people's anger or to talk them out of it with this notion of they should just be mindful and peaceful and accepting. But to know it's a healthy response. It's just about what we do with that anger, right? So Judith Herman in Trauma and Recovery talks about, constructive anger versus destructive anger. And so sometimes our constructive anger can mobilize us to take positive or proactive action versus our destructive anger, which can lead to our own harm and being immobilized in the rage. It's important to work with your clients around internalized racism. Internalized racism is when we come to believe the lies we have been told about ourselves. And so, how does your client feel about their own racial identity, right? Do they see themselves as less or see themselves as an exception? So they don't like the members of their community except for themselves. And so it's important to heal that, to have a positive sense of racial identity. Coping strategies are an important part, and most trauma recovery models end with teaching people how to cope. But we understand from African-centered psychology, multicultural feminist psychology, liberation psychology, that resistance strategies are important as well. And so helping the client to explore what are the possible ways they can respond or would like to respond when these experiences occur, right? And so for some, that will mean I'm not going to go back to that business anymore because they mistreat and are not respectful of African customers. For some, it may be protests or marching or letter writing. For some, it is filing a complaint. For some, it is being active in community organizing and even submitting statements to government officials to try to get things changed. So there are a range of ways that people can respond, and especially if people have not had a lot of these experiences before, or the support was not provided before, to create space for the dialogue, that it is not just about emotional coping, but considering a sense of empowerment and what, if anything, can be done. So, holistic therapy with displaced persons is important as we consider that trauma, as I named in the beginning, is not just about cognitions. So, individual talk therapy alone can really be insufficient. So, trauma shows up in the body, and I am glad that increasing research is being done on what some call embodied healing or somatic healing or trauma informed yoga, mindfulness. So, being tuned into the body and helping the client to become more aware of interoceptivity, the ways in which their emotional life shows up in the body. It is important to integrate that because sometimes people are intellectualizing and rationalizing, and we're ruminating and stuck in our heads and in our thought life. And some of our interventions really encourage that, this disconnection really from the self. So we want to be mindful of incorporating, whether that is stretching, whether that is progressive muscle relaxation, the ways in which the body can be encouraged, the ways we can encourage clients to be present in their bodies, because trauma disconnects us. It disconnects us not only from our thoughts and our feelings, but also our bodies. When we consider the diversity of cultures, we also want to consider respectfully and ethically spiritually integrated care. And so research in the States demonstrates that on average, mental health professionals endorse a lower rates of religiosity and spirituality than the general public. And so often people who are designing these interventions may be persons for whom faith is not central, but then they're applying the interventions. We're applying those interventions with people who may hold their spiritual and faith lives as very central to their identity, meaning making, and coping. We also know from the research that women and persons of color endorse higher rates of religiosity and spirituality. So you want to assess and respectfully integrate when people desire that to be a part of their interventions, that in their therapeutic process, right? So we think about positive religious coping. We think about solutions-focused therapy. What are the things that have been helpful to you in the past, and to make use of those things in your present. So if people said, when things were more stable for me, that prayer was very helpful for me, or going to my religious services or reading sacred texts in the morning helped to ground me, right? So then we're not telling people who aren't interested in that they need to do it, but for those that has been a part of their meaning making and solutions, sometimes the trauma and displacement have disconnected them from those rituals, from those routines, from those behaviors. And so we can encourage and foster that reconnection. Being culturally informed is important, attentive to advocacy needs, paying attention to the systems in which people are engaging, and having family and community-based approaches. And so a number of indigenous communities have talked about European and American psychologists coming in to work with them and immediately separating them from others, and having this big kind of focus on sharing your secrets to the stranger while you're disconnected from your own family and community. So we want to be really mindful that individual interventions can be helpful, and at the same time to consider, family work, group work, and also disseminating information within the larger community. One of the interventions we look at is trauma-informed music therapy with refugees presenting with PTSD. And these are culturally adaptable treatments incorporating music interventions. And we saw similar positive outcomes as talk therapy, but with significantly lower dropout rates. So when the music was utilized, people were more likely to stay engaged, to stay in treatment. And they used in this study Western classical music, New Age music, and music from the participants' own national culture to generate inner imagery following a phase treatment protocol. And the homework that was provided entailed them listening to music on their own. So you want to consider the ways you can integrate the expressive arts, including not only movement, but music. So this liberation psychology framework, I want to tell you, emerged out of Latin America. The founder of liberation psychology was both a psychologist and a priest. And so the work is at its core holistic, and so it is spiritually integrated. And it also really calls for us to be intentional and consistent in addressing oppression in our clients' lives so that we're not operating in denial or minimization or simply stopping at awareness raising, but then looking at how to address the oppression. A part of liberation psychology is consciousness raising to help clients to be aware of the systems in which they are working and interacting, to be able to give voice to their exposure to stereotypes, stigma, and discrimination. Liberation psychology also includes problematization, which really is about not conceptualizing the client as the problem, right? The client is not the problem. The client is facing trauma, loss, oppression, racism, and that is showing up in their symptoms of distress, as we would expect symptoms of distress to emerge when people are confronted with so much loss and trauma and grief. Liberation psychology incorporates both coping strategies and resistance strategies, and it also utilizes what some have called indigenizing approaches. And so recognizing a part of what can be therapeutic or healing is culture. So culture can be a part of the medicine of actually integrating it in our discussions in therapy. And I have to say, this is not appropriation. So it's not pretending someone else's culture is yours, but from a place of cultural humility, creating space for them to be able to talk about cultural resources, and then in their homework to be able to apply it, to reconnect with their culture, their cultural community, perhaps cultural rituals, and accessing those resources in their healing process. So with indigenizing psychology, we consider the promising practice example of the Tree of Life, which is culturally grounded, a strengths-based group counseling approach, addresses traumatic experiences, recognizes participants' cultural differences, aids in instilling confidence and hope for the future by exploring but not centering the trauma, but discusses roadblocks, but also develops a second story. So helping clients to think about a story that is not just about their trauma, but about their hopes, their aspirations, and their skills. So it has an empowerment lens. It utilizes art and a collective narrative, so storytelling practice within the group that considers cultural beliefs and values. And so the primary developer of this approach really comes from umbilical, comes from the Zulu word, which is a cloth used for African mothers to carry their babies on their backs. The cloth provides warmth and the capacity to hear their mother's heartbeat, which in treatment includes reflecting on culture, values, ancestors, important relationships, and skills, right? So when we want to provide warmth and a connection to the heartbeat, that really is about reconnecting with culture and those important relationships. So finally, I want to name that sustainability is going to be important for you as you think about providing care in a conflict or war zone or in a place of resettlement. Also, as you're providing care in the midst of a global pandemic. And so the realities of burnout are real, and many of us have full loads. You also, as you are looking to stand against racism and other forms of oppression, may experience racial battle fatigue, that it is exhausting to experience and encounter racism, and also to try to be a change agent in our field where many people have been uncomfortable or silent or even actively resistant to the incorporation and addressing of racism. So we recognize this work we're in, this process that we're in is not a sprint, it is a marathon. And so war and conflict are ongoing. Racism and other forms of oppression are ongoing. And so I invite you to be intentional and mindful about the ways that you refill your well. And so for us to think about boundary setting, knowing when we have already done so much that we're not in a place to take on more clients, for us to be mindful about the care of our physical bodies, and so giving yourself permission and space to rest, being intentional about your meals, about drinking water, being intentional about cultivating mutual and reciprocal relationships. And so, as a psychologist, you're often pouring out and being of service to others, but really being mindful about putting yourself in positions to receive, to not just give. And we can also refill our well with our own spiritual practices, with the expressive arts, and also with working around prevention, so that we can know we are not only in the aftermath, right? After war, in the aftermath of a racist incident, but for us also to apply our services to trying to disrupt and prevent these events from happening, so that we can be a part of the solution. I am so grateful for the work that you do, and grateful for your time here with me and with the American Psychological Association. And we can end on today with a compassion hold. And so if it aligns with you, if it's comfortable with you, I invite you to place one hand on your heart, one hand on your belly, tuning into your breath at your own pace, paying attention to the inhale through your nose and the exhale through your mouth. Thank you so much, and take good care.